Now coming to the principle, why you do lower extremity revascularization. This is the normal vessel and this is the disease vessel. In normal vessel, you can see the arterial cross section, the lumen is wide open and the blood flow is adequate and the blood supply is maintained. But here you can see the diseased segment. In diseased segment, there is atherosclerosis and the vessel lumen is narrow and the blood flow is reduced to that diseased segment. So you have to overcome this blockage and establish blood flow to that diseased artery. That is the principle of doing lower extremity revascularization. How it can be done. And the options available for us for lower extremity revascularization is, one, you do a balloon expandable cover stent or a self-expandable stent, or you do an endarterectomy patch. You place an incision over the artery, remove the endarterectomy and cover the vessel wall with the patch, or you can do a bypass graft. From the proximal part, you connect to the distal part, so the blood flow is established. These are all the various options which is available to us. Either stenting or with surgery. Stenting, you can go with balloon stent or self-expandable stent, and with surgery, you can do an endarterectomy with patch or you can do a bypass grafting. Coming to the perioperative management, there is increasing use of effective antiplatelet and anticoagulation medication, particularly in lower limb ischemia. And this is really challenging because of the risk and the benefit. What is the risk? There is going to be increased risk of bleeding if you continue in the perioperative period. What is the benefit? It is going to prevent the thrombosis. So once you withdraw, there is going to be higher risk of thrombotic complication. So on one end of the spectrum, there is bleeding on continuation, and another end, if you discontinue, there is thrombosis. So you have to analyze the risk benefit and continue the antiplatelets accordingly. Coming to single antiplatelet therapy with symptomatic peripheral artery disease, there is 23% reduction in critical vascular event, and aspirin efficacy in both symptomatic patient and asymptomatic patient is well established. But still, large randomized trial is required to prove the outcome with aspirin. Whether it increases the bleeding or improve the cardiovascular outcome, still large randomized trial is required.